Good morning, good afternoon, and good evening. Welcome all of you to this live program at Orthopaedic Principles. Today, our guest of honor is Dr. Neil Sheth from Philadelphia, Pennsylvania, United States. Dr. Sheth is the Chief of Orthopedic Surgery at the Pennsylvania Hospital. He's also Associate Professor of Orthopedic Surgery at the Hospital for the University of Pennsylvania and Affiliate Faculty for the Penn Center for Africana Studies and also Senior Fellow for the Leonard Davis Institute of Health Economics. Neil obtained his undergraduate degree in biomedical engineering with a minor in finance at the University of Pennsylvania. He then spent 2 years on Wall Street as financial analyst in Solomon Smith Barney's healthcare investment banking division prior to attending medical school at the Albany Medical College. Following medical school, he completed a 6-year orthopedic surgery residency at the hospital for the University of Pennsylvania. Subsequently, he completed an adult hip and knee reconstruction fellowship at the Rush University, as well as a 3-month mini fellowship at the Endo Clinic in Hamburg, Germany, focusing on periprosthetic infection. Dr. Sheth returned to the United States in 2012 to join the faculty at the University of Pennsylvania and focuses his research on bone loss pertaining to revision total hip arthroplasty, periprosthetic infection, and the role of orthopedic surgery in global health. If you've noticed, Dr. Sheth has delivered a couple of lectures on our channel, which were very engaging. And today it's my great honor to bring back Dr. Neil Sheth for this wonderful live program. Over to you, Neil.
Thank you again for the invitation. I've really enjoyed the first couple of talks that I had a chance to give, and I think some of our engaged discussion. And so I appreciate the opportunity. I know it's late for you guys in India, but this is an important topic that I've recently become interested in over the last couple of years, which I think is going to make a huge impact in what we do taking care of some of our revision patients. So I want to talk about hemodynamic optimization and what the surgical view is from the perspective of orthopedic surgery, which is not really there right now, and I think it's something that needs to be. These are my disclosures, which are not pertinent at all to any of the material that I'm going to be speaking about. So this is the kind of patient I'm thinking about when I think about this topic of hemodynamic optimization. So this is a guy, his name is Bill. He's 58 years old. And this is an x-ray from 7 years ago that I inherited this gentleman who unfortunately fell, had a hip fracture, was treated with a hemiarthroplasty. The hemiarthroplasty unfortunately failed, and he fell with a periprosthetic fracture, and they revised him to a stem with some cables, and it converted him to a total hip replacement. And then unfortunately fell again, had a repeat periprosthetic fracture, which they just decided to plate. And then at that point, they sent him to me for definitive care because now he had a draining sinus tract and had infection in this periprosthetic fracture. I have taken care of him over the last 7 years with multiple surgeries, trying to reconstitute his femur, trying to clear his infection. And it's been a challenging go at it for certain over the last better part of a decade. Well, now he presents at this point, about 7.5 years later. You can see his right lower extremity is significantly short and externally rotated. And if I look at his x-ray, the last surgery that we did was a proximal femoral replacement, which lasted for about 2 years. Thankfully, no infection, but you can see distally on the femur that there are radiolucent lines between the cement mantle and the bone. And I'm afraid that this is now loosened, and he has noted that his right leg has started to slowly externally rotate more and more. I don't think the cement mantle is holding. So we did just recently, about 4 months ago, did a total femur replacement. You can see how much residual bone he had left. So not a lot of bone stock and real estate left. You can see what we've put in. And this is a total femur replacement where we have coated the implant with antibiotic cement. And this is his post-operative x-ray. And he's actually done okay with this. Well, so one of the questions that we always ask at the end of the surgery is, what is our blood loss? And I'm not sure anesthesia looks at the floor. This is my fellow on the left, and this is one of our residents on the right, and they're closing the wound. And you can see how much fluid there is on the ground, including blood and IV fluids and whatever else he's lost during the surgery. But we still commonly ask the same question, say, what was blood loss and what was fluids? And for us, it's more specific because we need to put this in our dictation. And you get some values back, right? The blood loss was 1.4 liters. This is about a 3.5 hour surgery. He only got 3.5 liters of crystalloid fluid. We gave him a little bit of protein, also 500 cc. Yeah, we thought we should give him 2 units of packed red blood cells because he was losing a lot during the surgery. Cell saver was 250 cc, so we were able to give him back a little bit of his own blood. And urine output was only 200 cc's, but that should be okay. And the question I have is this truly accurate? Are we basing decisions off of these numbers, and are we getting a good sense of what the real sense or state of the union is for one of these patients? Now, when I think about the value of care that we deliver to any patient, value, I think, is a function of quality of care that you deliver, the service that you actually give the patient. The patient must have access to care, and we have to do it in a costly, in a fashion where we can conserve cost. Otherwise, the value is diminished. And when I think about specifically here in the United States, this is what most of our big health centers are paying attention to, is the U.S. News and World Report rankings. And you can see the top 20 hospitals in the United States. And of course, donors and high-level administrators at hospitals want to be in the top 5 in the United States. But how do we get there when we're taking care of patients like Bill, right? When they're looking at specific things and specific metrics, such as the number of patients that are discharged to home and not to rehab, and what is the patient's experience, and how many patients are the length of stay is short, and their reoperation rate is low, and their complication rate is low. Does this really fit to patients like Bill? So in 2021, this is just recent, in the last 3.5 months, our Medicare Medicaid system, which is the government insurance, has released an announcement that they have now taken inpatient only list patients off of the list, which means patients like Bill that need a revision are no longer considered only inpatient surgeries. And I'm not sure how to take care of that type of a patient without offering him an inpatient stay for several days. I need to watch his wound, I need to check his cultures. He's going to need some more fluid resuscitation because he had a major operation. It's going to take him time to be fully weight bearing and strong enough with therapy. So he's going to probably need to go to rehab. These are all things that are against what the government is asking us to do. So now I relook at that value equation. And now I think the quality of what I can offer the patient is less if I can't give them the quality and service of what I think they need in order to take care of their problem. Over time, patients like Bill are going to lose access to care. No one's going to want to take care of him. Because of what? The cost is too high. The hospital is going to much rather want me to do 4 or 5 hip replacements on healthy patients that are going to do very well and have a very low likelihood of complication and reoperation and have a readmission to the hospital. That's what minimizes their cost. But I don't think with this value proposition, I can deliver the proper care, the adequate care, and still maintain access for care for patients like Bill. If I look, this is a separate study that we're doing, and we're actually looking at publishing this literature and publishing this data in the literature soon, is looking at revision total hip arthroplasty costs and charges that we've been seeing over the last decade and a half. And you can see the trend has literally gone up 3-fold over that time frame. So the cost and the charges that we're seeing for these procedures are continuing to go up. And everything that we're being told from the government's perspective, from insurance companies in the US, and I understand that the situation and the environment in a country like India is different, but we are being pushed to move everything to the outpatient setting by trying to optimize patients for outpatient care. So then my question becomes, what are we incentivized by? My incentive is to do a lot of volume with low complication rates, low length of stay. Everyone goes home and people are doing great. My incentive is not to take care of patients that are complex revisions. Now, being at an academic center, that's 40% of my practice. A majority of the patients that I take care of that need revisions are coming from other hospitals that require some level of higher level care, and so they send it to the academic center. But if my incentives are not in line with taking care of that patient, how can I deliver value-based care to that patient? We've spent a lot of time looking at the literature, looking at how to optimize patients for surgery. And it's amazing that, there's data out there that almost 20% of the money that we spend in healthcare is wasted. So can we do something better? Can we get patients in better shape prior to surgery? So there are things that we can modify, which will help us both on cost of care that we deliver as well as postoperative outcomes. Nutrition is something, there's a lot of literature on this in the last several years. There's some of the literature has come out from our institution at Penn, as well as from some of my partners here, looking that nutrition alone is an independent risk factor for having postoperative complications. Diabetes, something that's been in the literature for a long time, even in non-operative patients, but definitely in the last decade. Diabetes control and perioperative glycemic control is very important to help make the immune system work properly, to heal properly, and to minimize complications. Chronic disease management. There's a lot of medications out there specifically that are available for certain diseases like rheumatoid arthritis or some of the other inflammatory arthropathies. And trying to get these diseases under control and managed better will again help the patient's profile to minimize their risk of having a complication after surgery. Obesity is a huge problem here in the United States. We'd say probably almost 30% of our patients are obese, and some of these patients, especially here in Philadelphia, we have super obese patients, patients who are BMI 50 to 80 who are coming in with some of the same problems. On a primary joint replacement, we can modify and we can restrict access to say you're not ready for surgery, but someone comes in with an infected total hip replacement at a BMI of 70, I don't have the ability to say that, listen, I have to optimize you and you need to lose weight before I take care of this infected joint replacement. So is this truly modifiable for some of these revisions? And the last thing is smoking status. Again, there's a lot of literature in the last couple of years that has really looked at smoking status and trying to minimize the use of nicotine to help maximize or optimize the blood flow around the region of healing so that you don't have a wound healing problem after surgery. I think there's one other thing that we have not done a good job on is perioperative fluid management and maintaining an optimal perfusion. And I think a lot of this has a huge role in those same factors, getting patients prepared for surgery, treating patients intraoperatively, treating them postoperatively, and minimizing your cost as well as minimizing postoperative complications. There's a very nice paper out of Britain, and this is in the general surgery literature, that they've actually demonstrated that there is an optimal range of fluid volume resuscitation. If you hypoperfuse someone or keep them hypovolemic and under resuscitate them, the complication rate goes up, which is on the left side of this chart. If you over resuscitate someone and give them too much volume, there's more edema, organ dysfunction. Again, they're in a hypervolemic state, and you can see how the complication rate goes up again. The literature is really clear in the colorectal and cardiac world, where we know that increased fluid overload leads to decreased patient outcomes when we're talking about surgical patients. So I started thinking about this about 3 years ago to say there must be a role for this principle and this fundamental concept in the setting of revision total hip arthroplasties, where the procedure length and duration is much longer than a standard total hip replacement. We have unpredictable fluid losses with inaccurate blood loss estimates, like I showed you before. We don't use a tourniquet like you do maybe in a primary knee replacement or a revision. And there is a role that some of these principles may be applicable to the revision hip world. So we started looking specifically at my patients as a pilot study and looking at fluid overload and revision total hips. There was a two-part hypothesis. We figured that the longer cases would have more fluid overload. The second part of the hypothesis is that if you have fluid overload, we thought there would be more adverse patient outcomes, specifically for an increased need for postoperative care and surveillance, which means patients going to the intensive care unit for monitoring afterwards, and an increase in complication rates. So what we did is, over a span of about 6-7 years, we looked at 300 consecutive revision total hips that I performed in my hospital. And we recorded their procedure times, recorded all the intraoperative ins and outs with regards to fluid resuscitation. And then we did a multivariate logistic regression model. And we tried to basically determine what the impact of one positive net liter of fluid would be on postoperative outcomes. Kevin Peruccio is one of our fourth-year medical students, a very bright guy who's been working on this for the last couple of years with me. He's going to be graduating in a couple of months, starting his residency program at Yale in orthopedics, but he is the one who has done a lot of this work with me. What we found was interesting and in line with our hypothesis. basically surgeries that were less than 2 hours long. So these are the smaller green bars. You can see that the frequency with which we saw a net fluid balance of more than 1 liter was few cases. You can see as you got to longer cases, greater than 2 hours. So we're talking about incision time to putting on the bandage. You can see the number of times and the frequency with which we saw a greater than 1 liter of net fluid positive balance, which means even short cases or long cases, we're not keeping people euvolemic at that level where there's really no positive fluid balance. Well, we took this one step further for that second part of the hypothesis, and we saw what happened with 1 positive liter of net fluid balance. And you can see that everything turned red. The incidence of postoperative ICU transfer, the requirement for some type of resuscitation, whether it's fluid boluses or pressor requirement, the need for more postoperative day labs, increased length of stay was greater by half a day, pulmonary complications, vascular events. So this was not benign. And in line with our hypothesis, we saw that there were a majority of patients that had higher complication rates because of more fluid resuscitation than they needed. We put this together as a poster and just presented it at the Hospital for Special Surgery in November. Again, looking at that data, showing the same output with regards to what the complication rates were. And the question was simple. Are we hurting our patients by neglecting intraoperative volume overload in revision hips? Is this something that we just haven't thought about? And is this something that we need to make this a much more of a priority when we're thinking about these revision patients? I believe the answer is a very clear and resounding yes. So I've been now partnering with a company called Edwards Life Sciences. They have a device which can be hooked up to an arterial line. It's called a FlowTrack sensor. Again, I have no vested interest in this company. I'm not a consultant for them. I don't get paid by them to talk about this device. This device, though, was basically derived from me looking at our intensive care unit team and our cardiac colleagues to see how they monitor fluid volume and volume requirements in the operating room. And basically what this device does is it gives you volume outputs and measurements almost like you have a Swan-Ganz catheter in place. The big thing is they give you stroke volume variation, in addition to all of these other cardiac numbers. But the stroke volume variation is the key one that tells you how much your heart is working to basically circulate your blood volume around during the surgery. And are there things that we're doing, are there parts of the procedure where we're experiencing more blood loss, we're in an area of the hip that has a lot more redundant vasculature, we're losing more blood? Is our stroke volume variation dropping? And as a result, are we seeing some changes in the cardiac output? Clearly, to look at this type of a thing needs a multidisciplinary approach. So I've had to spend a lot of time with our anesthesiologist, talking to our OR nursing staff, talking to the surgical team, not just the surgeons, but the OR nursing staff, the circulating nurses, and everyone who's going to be a part of the team that's taking care of that patient. Talking to the recovery room nurses, talking to the floor nurses, talking to our intensive care unit partners, and then again, partnership with industry in this setting because they have a device that works well and will fit into our workflow is a key part of actually making this happen. The nice thing is with our anesthesiologist, we actually looked up all of the data that has been published on this FlowTrack device. And the nice thing is that there are different protocols that you can use. So you can use a protocol where they use inotropes mainly to be able to maintain your fluid volume versus using fluid versus using blood, using colloid, do a whole different number of protocols that you can use. But with our anesthesiologist, we figured out that stroke volume variation was probably the most appropriate for what we are doing in revision hip surgery. So now we are engaging in a prospective study, which will start next month. And essentially what we're doing is going to do intraoperative, non-invasive cardiac monitoring using this FlowTrack device. And we're going to basically look at my revision total hips, and I will include my partners in this so I can get a higher number of patients. And we're going to basically look to see what the complication rate is if we can control the patient's volume status and minimize fluid overload. We have a couple of objectives in this study. Number one, we want to look at the effects of this device on our ability, and basically our anesthesiologist colleagues' ability to maintain euvolemia during revision total hip replacement. And we think the secondary objectives are that using this goal-directed therapy and looking at the stroke volume variation protocol, we can really control IV fluids, blood product administration, and look at the patient's disposition, length of stay, and their overall medical and surgical complication rates. We're looking at 100 consecutive revision total hip patients that all have surgeries that are greater than 2 hours long, since we've already identified that cohort as being the cohort that's at risk. And the nice thing is that we have a group of 300 historical controls. So we can change the protocol, which right now we're not doing anything other than giving very inaccurate assessments of what the blood loss and fluid requirements are. Use that as a control, do this as a study arm, and compare that to the control to say, let's see what the difference is, and has this made an impact? Study details, we're doing this over the next 2 years here at Pennsylvania Hospital, looking at patients over the age of 18 that are undergoing a revision total hip. We'll use the intraoperative non-invasive cardiac monitoring device. Again, we're using this anesthesia-directed resuscitation protocol, which they have chosen. And again, the treatment of the patient at different times of the surgery will be based on output device met parameters that we see from the device. Then again, we'll do a multivariate regression analysis to see what makes sense. The endpoint, again, we want to see what percentage we can affect with what percentage will have a greater than one postoperative complication within 30 days, and look at both medical and surgical to see is it fluid related. Secondary endpoints, we want to take a look at the measure and change in net intraoperative fluid administration, the percent of patients that are discharged to the ICU versus the floor, and then eventually whether they're going to home versus rehab. Look at the 98-day readmission rate, look at their length of stay overall in the hospital. I think the goals of this are to enhance recovery, decrease complications for our patients, and improve outcomes. Right? And the nice thing is that we are now embarking on a second component of this study, looking at something called a hypotensive predictive index. And apparently, if you can determine what percentage of time the patient spends during a surgical procedure under a mean arterial pressure of 65 or below, then you have an 85% predictive value of being able to determine that the patient is going to become hypotensive. And if that's the case, then you can preemptively treat the patient, keep them hypervolemic during that time so they do not become hypovolemic, under-resuscitated, and hypoperfused. In summary, I think orthopedic teams need to do better. I am really passionate about this because I think this is something that's going to change our ability to take care of patients. But I think really realistically, I want to make sure that patients like Bill have access to care and that they are not losing access because they are a cost-losing proposition to a hospital. And I think that this is one of the things that we can demonstrate. If we can demonstrate the right effect of taking care of fluid management, we will be able to demonstrate cost savings, better outcomes, and a rationale for still wanting to and being able to take care of patients like Bill going forward. Thank you for your attention.
Thank you, Neil, for your fantastic presentation and your revolutionary concept on fluid balance. Couple of questions.
Yeah.
See, we have discussed that a slightly positive one leads to poorer outcomes, right?
Yeah.
So do you think, for example, when we do trauma, we discuss, say, hypotensive resuscitation is slightly better. So do you think euvolemia or a slightly negative would be leading to better outcomes?
I think so. I think at least euvolemia has got to make a better difference. Being or under-resuscitated and hypovolemia, it may have an effect. I'm not sure how I would differentiate between euvolemia and how much hypovolemia. I think the first thing is I have to show in the prospective study is that if we can get you euvolemic, you have to be better than me over flooding you with 5 liters of fluid. The study that I showed that graph from is actually an interesting study from colorectal surgery because they looked at 499 centers in the United States for all patients who are undergoing low anterior resections for colon cancer. And all the surgeries were, I believe, under 2 hours. They saw a difference in fluid administration between 1.5 liters and 5.7 liters of fluid across the United States in different centers, depending on what protocol they were using, depending on the anesthesiologist that was covering the case, depending on the nurse anesthetist. It's an incredible amount of variation. We've got to do a better job. We just don't have the information, right? I'm focused on the hip. They're focused on the numbers on the screen. We're not talking during the case. And at the end, we just hope that the patient has made it through the surgery. I've done my job right and put the implants in the right position. And they hope that the patient gets out of the operating room safely to the next phase of care. I think that we can really capitalize on some of the technology that's out there, not recreating anything, but just learning from our colleagues in other surgical subspecialties. And I think this is applicable to our revision patients for certain.
And is there an additional cost involved? Like how expensive is the device? Or is it available already there in your hospital?
It's already in our hospital. Our surgical ICU team and the cardiac team already uses it. We are looking, we've submitted a grant to Edwards to basically give us the device for 100 patients. But if I can demonstrate that this works, I believe the cost is $200 per case or $250 per case, which if we can demonstrate that this works and actually has better outcomes, for the patient, it would be no cost. The insurance companies will foot that cost of $250. But, again, we can quantify the cost because giving units of blood and giving albumin like that is not cheap, right? That all of a sudden can be over $250 easy. So it'll be a cost benefit and sort of opportunity cost of doing one thing over the next.
Thank you, Neil, for that. Just one last question before we wind up. For the benefit of joint replacement surgeons all over the world, what is your threshold for giving any sort of supplementation? For example, if the albumin level goes down below a particular level in your joint replacement, because we know that hypoalbuminemia is not good for wound healing. It causes persistent discharge. And how do you really go about it? Do you give albumin or protein powder? How do you go about it?
A great question. So that's another study that I'm working on right now. Because I have been for the last 9 years, 10 years in practice, I have always looked at albumin levels before surgery. Even before hypoalbuminemia and before nutrition became a much bigger issue, I've been doing this ever since I finished my fellowship. And I've always thought about that because looking at general surgery, half these people are NPO, they're not eating for a long time, they're getting this enteral nutrition, and that's the only thing that's allowing their abdomen to heal or their big incision on their belly. Why is this any different if we're doing a joint replacement? The good thing is that 95% of what we do is elective. So if you are not optimized, I'm going to hold off. So I look at albumin levels. They have to be above 3.5 grams per deciliter. Realistically, I want them to be above 4. What the study we're looking at now is there's a protein powder that I've been working with called MEND, M-E-N-D. MEND is basically, I think you guys have this in India, but there are Boost and Ensure shakes that have protein in them. But the problem is that most of those shakes have a lot of sugar also. So for our diabetic patients, you're causing some other problem, which is no good. MEND, we are looking specifically at 2 things to say, if I treat you with this MEND powder shake once a day, twice a day for 2 weeks, how much will your albumin change? Right, over 3 weeks. It takes usually 3 weeks to see a change in your albumin. And number 2 is I want to see what happens to your creatinine. If I'm protein overloading, my 80-year-old patient who has bad kidneys, am I making her kidney function worse? But these are questions we don't know. Even right now, if I were to give someone Boost or Ensure, I don't know the answer to that. And I don't know where the threshold is. So we're trying to figure out that threshold because I think it's important. And I think some of these parameters around what we're doing for patients is going to make a bigger impact on how patients do, on minimizing cost, minimizing complications, so that those people don't lose access to care. Otherwise, there's no benefit in taking care of that patient. other than the fact that you know how to do it, your team knows how to do it. But at some point, I'll get a phone call from my CEO saying, listen, don't accept this infected patient from so-and-so because this is going to be a money loser for us.
And currently, what do you follow? For example, in your post-operative period, you get the albumin, say 2.9. And how do you go about it? Do you give fresh frozen plasma or human albumin?
Great question. So post-op, the patients that I see that on are my revision patients, right? Some of these patients come in with a periprosthetic fracture. Their albumin is 2.7, 3.2 pre-op. I have to take care of your problem. I can't optimize you. So what they will do is for their wound, if I'm worried about their wound healing, because of their protein level, they will get these protein powder shakes once or twice a day in the hospital, assuming their kidney function can tolerate it. And they will have an incisional wound vac on during that time. And that wound vac is put on in the operating room. So it's before anything starts draining. It's not because there's drainage and there's seepage from the incision. And then we keep them here for a few days and watch their albumin over time. We'll also get a formal nutrition consult in the hospital, which will help guide some of our treatment. But a lot of their treatment is really sort of these over-the-counter or these protein powders that can really help out with patients.
Thank you, Neil. I think that's all the questions that we have for this session. Fantastic lecture, really new concept. I'm sure it's going to kick up rapidly all over the world. Thank you so much for joining in.
Thank you very much. Great to see you. Everyone stay